morning, good evening, good afternoon, good night. This is the Mid-South Healthcare Innovators Club. Today, where the topic is the why of healthcare data with Doug Fridsma, and the tag of today specifically is that data beyond patient portals. If you are new to this club, just please go to the little green box on the top and click, and you'll have a little profile, or you have a link to all our events that are planned for the week calendar, and usually it's updated every Monday. And also you will have a link to a Discord server in which there's a lot of the information that we have talked about in other rooms and other events, and you can access them there, links, images, documents, topics, etc. And beyond that also, if you have any question at any moment, please raise your hand. Just be aware that you have some sort of blurb of information in your profile and some Twitter or Instagram account linked, so we know that you're a real person. And so that will be for today. That's the topic. If follow your moderators, follow your co-hosts if you're interested in this topic and in these rooms, so we can always tell you aware that these rooms are happening. So Doug, so we were talking about we had talked about since last week. It's been a week since the CARES Act and the deadline, and so we talked about how patients have access to, legally they should have access to their own data and do with it what they want. But we always focus on patient portals, how the patients just can go to a specific site that their medical provider or the health system provides them with, and they look at their data. But there is a whole other world beyond that specific usage of the patient data access. So, what do you think about that? What do you think that there will be? What's the space beyond a patient portal for people in their data?
So, Guillermo, thanks for kind of setting the stage. I think part of what I hope to accomplish, and so people that are in the audience or that are listening in, I think start kind of thinking about your own experience with access to your information, both positive and negative, and then those of you who are thinking about opportunities in the health IT space, working on a project or other things like that. Again, it'd be useful to sort of get your perspective on things as well. But Guillermo, to sort of set the stage for the conversation here, you did a nice job sort of articulating. Last week, the Office of the National Coordinator finalized, or actually, I shouldn't say finalized, it actually became effective, some of the information blocking rules that were passed as regulations just a couple of, I guess last year, a couple of months ago. And what's important about that is that it really sets into regulations that patients have the right to a comprehensive view of their medical record, and that not only can they access it directly, but they can also have third parties acting on their behalf to collect and to get that information for the patients. And this is, I think, important because historically, patients initially had access to their information through a portal. And so you'd go to your doctor's website or through your EHR or hospital's portal, you'd be able to sign in and be able to look at your information online. And at the time, that wasn't considered adequate enough. We wanted to really make sure that patients not only had passive read access to their information, but they had the ability to actually download it and put it to work for them. And so in Meaningful Use Stage 2, there was a provision included in there called View, Download, and Transmit that allowed patients to view their data, that would be through a portal, to be able to download it, a copy of their medical record to their device. And then the other was to transmit, to have third parties acting on behalf of the patient to transmit that data to another site or to another app or something like that. And so that was sort of setting the stage. A lot of people provided, a lot of institutions provided access to patients to be able to view their data through portals, and a lot of organizations had the notion of a tethered portal, the ability to sort of lock patients into a particular ecosystem because they couldn't share their data outside of the portal. And so, if you're being seen at a particular hospital, you end up finding it more convenient to just stay within that hospital system than to venture out where you might get different, better, or cheaper care. And so the effort was to unlock the data to provide some degree of flexibility for patients to be able to move to other areas. And so we are seeing a little bit of that. I do think that we're still at a place in which there's sort of a multiplicity of portals. If you've got a couple of different doctors, you may often have multiple portals that you need to get to. Although as people are adopting back-end systems through some of the big vendors, those vendors are creating a more integrated system. But again, it's keeping you locked in a particular platform or ecosystem. What the information blocking rules from last week really allow is what I'd like to call, and I can't say that I'm the one who came up with this, but Corey Doctorow from the EFF does a lot of writing in this area. But this notion of adversarial interoperability, that in fact now it's possible to get data from your electronic health record and be able to transmit it or to be able to use it in a way that is not aligned with, say, the business interests of the organization in which you've taken that data, which means the data now can work for you as an individual and as a patient. And so I think what we'd like to be able to talk about today in this room is, I think, two things. One, how many people have had experiences with using their data outside of, say, the patient portal, or is the patient portal still the primary means by which people gather that data? Has anybody ever tried to download their data or take a look at it? What does that look like? And as it's beginning to be, at least within the healthcare space, something that's more than just health data, but it's also beneficiary information from your insurance provider. Medicare, for example, has a lot of the beneficiary information about billing and other things like that are available for download as well. So a lot of the data is available, but it's still sort of available only through portals. And I'm just curious if there are folks that are either A, using the portals and downloading the information, and what are you doing with it? And then I think the second question is, are there other apps? Are there other products and services that people are using to be able to kind of take their data and integrate it with other systems? And so I just sort of be curious if there are folks that have those kinds of experiences. And Guillermo, I'll turn it back to you if you want to start with that conversation, if you want to ask a different question while people are sort of collecting their thoughts, or if there's anybody who'd like to come up and talk about some of those topics.
Yeah, as Doug said, if you're either somebody who's in the realm of using patient data for any reason, business-like or healthcare-wise, but if you also are somebody just a common person who has also been a patient and has experience with the patient portal, please raise your hand. And the idea is to try to understand what's your experience with your own patient data. Do you think that patient portal is enough, is what you need, or do you think that there is other needs that you're not being fulfilled by the patient portal? And in my own experience, though, going back to as a patient, when I have access to my patient portal, I feel like there's sometimes things that are there that are posted there that if I didn't have a medical background, I would easily misinterpret what I'm reading or what I'm seeing in the screen because of the colors, because of the wording. So having said that, would it give it a little bit more complexity to the end user?
Guillermo,
yeah.
Before we continue, I think we need to note that this is a recorded session, and that anything that you guys are saying, especially the new people who came up to the stage, is going to be recorded and released as a podcast. Today's April 20th, 2021. This is one of the first times we've recorded the why of healthcare data. I think it is the first time for this one, and we will be publishing this. So if you're not okay with that, please leave the stage right now. And if you stay, then we'll take that as consent. So thank you. This is Alex Fair from Bestseller Healthcare Innovators, and I am done speaking.
Thanks, Alice. I think, yeah, I totally forgot that to say that when I set up the room. And so, and to finish my thought to the question was, so, and how hooked up we are to the actual health system of the hospital and their UX UI to how we see our data? Do you think that if there's no uniformity, can we look beyond the patient portal, or should we still be looking and trying to make that a better user experience in general? That's I'm asking as a patient, as a patient, yeah. Guillermo done speaking.
So, Guillermo, I guess the question really is that, if you have access to this information, it's all being written in medicalese, and sometimes it's kind of hard to understand what's going on or things like that. I think there is a lot of conversation. I'm not sure that anybody is necessarily solved this problem entirely yet, but the notion of, taking a look at your medical record, lots of big terms, if you've got a 5% error rate, something is 95% accurate, and only 5% of the times it gets it. You could have a normal test that's read as abnormal. If you do 20 tests, very oftentimes when people do panels of chemistry tests or liver function tests and things like that, you end up with having at least one of those things be slightly abnormal, but not necessarily clinically important. And so I think there is a risk when people have access to all of their information that some of it can be difficult to understand. As a doctor and as a patient as well, I actually welcome the conversation if there's something that's not clear. And I think one of the things that it may do, and we certainly see this with some of the open note initiatives and things like that, is that one, while doctors initially are somewhat concerned about patients reading the notes and getting upset about things that they read, in general, there is overwhelming satisfaction to be able to take a look at the note, and that if it prompts a conversation for the doctor to clarify something or to be clearer with things, I think that actually is a good thing. That's something that prompts a good conversation. There are always those concerns that a pathology report that has a bad result might show up on a portal before the patient has an opportunity to take a look at that. But I think those are all reasons why it's important to sort of track that, and I think a lot of institutions have checks and balances in place that really try to make sure that the doctor is included in the loop and can provide some explanation to the results before they get out there. But to me, that just the solution is not to restrict the data. The solution is to find ways to provide better education and to alter the workflow so that patients who are waiting for the results of a biopsy, get that as quickly as possible, and the doctors are sort of on it to make sure that they're able to provide those results. So, and I'm Doug, and I'm done speaking for now.
Thanks, Doug. I think we have some guests coming up to the stage, and I'm going to say good morning, good evening, good night, Virginia. How are you?
Good morning. It's East Coast time for me. This is a really hot topic for me personally. I come from a medical family, but I'm a lawyer. So I appreciate the privacy sides of this. I appreciate the doctor's sides of this. But I'm also a caregiver for 3 parents, a mother, father, a stepfather, for 2 daughters with medical issues, plus myself and my husband. I have over 32 different portals that I have to go to if I'm going to cover everybody's medical profiles. And, this is the labs, this is the doctors, this is the hospitals, this is, across the spectrum. And for me, as an advocate for all of these patients, and these are only family member patients, it would be extraordinarily helpful to have a unified system of medical records where the doctors actually talk to the labs and the labs actually talk to the hospitals and vice versa. And whether that's achievable on a blockchain type platform or what, something should give, because the information is really valuable in the the dialogue with the physicians, but when you have to dig so hard to get it, or you have to remind a doctor to look at a lab so it can be released to me so then I can have that conversation with my mother's doctor or my mother's other doctor, it really is heavy for the advocates and the patients. I understand that the doctors would like to be able to see the results before the patient in order to be prepared for when the patient comes with the question. But I think perhaps that dialogue should also start before the test is ordered so that the patient knows what to expect when a test result comes in. I could go on for hours, but I will step back and listen for a while because I think this is a really, really important conversation. And if I can be part of the solution, I absolutely would love to be. Thank you.
So Virginia, so many nuggets in there. Thank you so much for kind of sharing your experience and things like that. I think your experience with 32 different portals is not unusual. And you know, I think what you also recognize is that when we talk about patient access to the information, it's not just the patient, but oftentimes it's the caregivers and the advocates and the family members that also want to be included in that conversation. You know, as a as a doctor, I have family members that will have a procedure, they'll have an ultrasound or something like that, and then they'll want to try to have me take a look at it and get my perspective on things. Now, I'm not an ultrasonographer or a radiologist, but they just, you know, there's a lot of big words and they want someone who can help explain and advocate for them on behalf of what the test result is, even if it's a perfectly normal test result. And I can't tell you how challenging it could be. There are some systems that allow you to share your medical record, but it's a one-time snapshot, and it's not possible for you to say, I only want to share my ultrasound report. I don't want to share all of my other reports. You know, you sort of get a link, you can sign in and you can take a look at things. There are other circumstances where people have given me their name and password and said, can you just sign on and take a look at this stuff? Which again, I think presents a whole series of issues associated with that as well. You know, and so I would say that, you know, the vast majority of people, what ends up happening is I get this enormous cut and paste into my my text message with the results and say, can you just take a look at this and tell me if there's something to be concerned with? And so it is a problem, and I think it is kind of an expected problem as we've got more and more data available in an electronic format. We haven't necessarily gotten it fully integrated. The last thing I'll say about that is that part of the challenge is that you know, people, you know, I think we still have a mentality that the portal can be served as a business tether to kind of get people connected, but they don't realize that you may only be seen in the hospital once. You may only be seen in the hospital once or twice a year. That isn't going to tether you to that hospital to have the need to go through the portal, and every time you do it, you have to update your ID and password and things like that. The big problem that we have, and that I think is still going to be with us as we go forward, is that if you wanted to fully connect everything, if you wanted everything to get connected to everything else, it's not a tractable problem. You can't have every doctor connected to every other doctor connected to every other lab system. Just trying to get all those connections to work becomes exceedingly challenging, and you sort of have to pick one. And some people, what they do is they pick their primary care doctor and make sure that they have all the information that's there, and then they focus on kind of that one portal. But there's usually a time delay in getting a lot of the information around. Other people try to sort of centralize it themselves, you know, sort of be the central point, which is, I think, a more efficient way to do that. But it also, you know, there's not a lot of good tools that are out there to help people to do that as well. So I think, Virginia, your experience is not unique. I think there's a ton of folks out there that struggle, particularly if they've got family members that they care for or that advocate for. And we have not yet gotten to the point where there is the kinds of solutions that can really act on behalf of patients and where they are at, and patients and their advocates, I should say. You also, and this is sort of the last comment, you mentioned blockchain. I mean, there's a lot of folks that are looking at blockchain as a potential solution to these things, but I think it's always important to really understand what features of blockchain you're trying to use in this space. I think things like non-repudiation is a really important feature of blockchain, because it says, once data is added into the chain, and it's all sort of confirmed, you have sort of a source of authority. But the converse is if something gets added to your blockchain and it's not correct, it can oftentimes be difficult to sort of change that. And blockchain is perhaps useful for a longitudinal medical record, but it isn't all that useful for just the exchange of information directly. So, stay tuned, Virginia. I think that there's going to be a ton of interesting things that are going to come down the pike now that as this data becomes more available. As we sort of started out, what you're really advocating for is, wouldn't it be great if there was a unified system or a way that somebody could advocate on your behalf to collect and aggregate all this information and provide a kind of a view into it that would allow you to advocate for your the people that you care for in your family, and to make this a lot easier as an experience. So I'm Doug, and I'm done talking.
I think that's really correct. What I would really love is a unified portal. I know Microsoft Vault was headed that direction, but that's now gone, and it never got into full use. But a verifiable portal, singular portal that all the other portals can feed into, that the patient has control over. And the errors issue was something else that I didn't mention that you did, which is actually something that is really critical, because I have seen multiple times that one doctor has information that is either old or for example, drug lists that haven't been updated, and then they're pushing that as the current drug list. And it's like, well, wait, we don't have a unity here. That's incorrect information. Let me update you. And the fact that you've got 2 different doctors or 4 different doctors prescribing different things, and there's no common basis for them to really know, other than what the patient says, what that patient is on. And as the advocate, I really try to keep on top of those things, but I am challenged by my father in particular, who doesn't have often a clear idea of all the things that he is actually supposed to be on. And he'll wind up in the hospital, and then he'll wind up home with a new drug list from the hospital that doesn't include those things that weren't relevant while he was in the hospital, but his GP really believes are important. For example, vitamin D and vitamin B12. And so these are things that, again, I don't have solutions at the moment, but I can see a lot of ideas on how they can work together just from my experience. And I'm really excited to be here. Thank you. I'll shut up now.
I would like to add something if it's possible, Alex.
Go ahead, Manas.
Oh, thank you. Good morning, everyone. This is Manaz. I'm a clinical informatic nurse, and I work in a post-acute care setting. And I hear you, Virginia.
Manaz?
Yes.
Manaz, just so you know, this is a recorded session. So
yes,
sir. Say can and will be used for a recorded podcast. Thank you. And this is Guillermo show. I'm just helping produce and bringing people in. Really great conversation. Also, Matt, make sure that you know that this is recorded, since you're new to the stage as well. Thank you.
Great. Thanks for the reminder. Virginia, we have something in East Coast, north part of the East Coast, that is called CRISP. And what it does, it just integrated with different EHR from the hospital, outpatient. And it's kind of like a hub, patient hub. They're working on a patient platform. And the reason I want to share this, I hear, and there is some program is going on, and I hope other region in United States is starting to create such a valuable platform. What it does, it just gather all the clinical information of the patient, which is very valuable, the test, the progress note, the hospitalization, if something happened in the community. I think it has been a great tool for us as a provider to track our patient. and also it has become a source of data collection in a COVID era, that we submit our daily infection rate, our census, that it's very valuable to show if, for example, if we have a high wave of the COVID infection and the hospitals overflow, which post-acute setting is available, and they can receive those overflow patients from the acute setting. That's one thing that I just want to share with you. There are some programs going on. The other thing that you mentioned regarding kind of being understandable for the patient. And believe me, we as a healthcare worker also sometimes we struggle, and we are not expert in all the area. And sometimes we have to go to Google and Google this and that. And I agree with you. And I was hoping when this Cure Act, when in effect, when they started in 2016, but it went live on April 5th this year. Before that, they had stakeholder around table like you and other people in a healthcare setting that they are dealing with the data collection and data reading on a daily basis to provide some more insight to this process and this policy, because I believe we should add a simple description at the top or at the end of any report to, if we want to provide those information to our patient or any other provider, to just, okay, this is normal or abnormal, what is the follow-up? Simple as that, not adding any extra dilemma on a patient's plate, or someone like Virginia that is not just a patient herself, also is a caregiver. Thank you so much. This is Manaz, and I'm done talking.
Thanks, Manaz. I don't know if you want to add something, Doug, or we can go to the next question with Hans.
No, I mean, I think I'd say let's continue the conversation. We can get back and talk about HIEs, which is really what I think Manaz is speaking of, because they have a unique place in this ecosystem, although they tend not to have, at least currently, it is not universal that patients have access to the HIEs themselves. So, but why don't we continue the conversation, and I'll step back in just a moment.
Yeah, sure. Yeah, and also I want to maybe touch the base, talk a little bit later about if we have a global hub for patient, would that be the central source of truth for all patient data? So the concept of source of truth, that will be a topic. But Hans, hi, good morning, good evening, good night. How are you?
Hello, good afternoon for me, good morning, I guess, for you. So this is Hans here. So nice to see you all and hear you all again. And Doug, last week, a great session, by the way, we followed up on that. So coming back to the core question, right? So I started my enterprise to help patients I was a dad of a patient. So I won't speak about tech and all of that stuff, but really about my patient experience. So I lost my kid, right? And when you're close to losing your kid, when you know already months up front that it can turn out badly with a high probability, you start to take some actions. And I luckily have a background in molecular biology and in medicine, so I can read things. The problem though is first finding things. Where do I go to find things? Like when you go to a physician, they only have 20 minutes to really look at it, and they do more than that. I'm just simplifying things, right? But when you go back, you're at home with your wife and a potential kid that's really, really, really sick. So what do? You can't even sleep. And when you have a background, you start to look. So I went into deep science papers. I looked up trials. Where could they help my wife? Where could they help my kid? And finding things is one thing. Then having access to it. So some of these papers were then hidden behind Nature or Elsevier, and I had to pay for it, right? Luckily enough, I was working in Big Pharma, and they were willing. I could use the license for that. So finding things is one thing. Having access to things is the other thing. And then it comes back to what you said, Doc, as a patient. So I live in Belgium. I've been a lot in the US, so I've never had issues in the US and never had health platforms there, but I've seen some. But in Belgium, it is very hospital patient platform. You get access, and even they revoke access after 2 weeks, which is super crazy. So the patient doesn't own the data, he doesn't get the data. And even on top of that, I want to make it interoperable. So I have the background, so I can understand the molecular biology. I can look for targets. I can look for drugs. I can even look at the chemical compound or the active ingredient and look at that. But how about the other people? So interoperability, how do you translate these difficult to understand terms in easy to use words that people understand it, that they know what this is about? When you hit a clinical trial, do you know what the stage 3 clinical trial means? Can you enroll for that? What are the inclusion exclusion criteria? So making things interoperable is a third thing. And then last but not least, I found a lot of extremely interesting insights. In fact, the physician told me that I knew more than him about the disease. Then we come to reusability. When I clean up a paper, when I do translations, for instance, mesh terms, and simplify it so people can find it with better keywords, I would love it to be reusable. So you see here, what I mean is data needs to be findable, accessible, interoperable, and reusable. And in pharma, we use the fair data principles. That's what we need to make it accessible. And then we can start thinking about the technical access, revoking access, security, potential blockchain doesn't scale at this point, and how can you give access and revoke access? Because I, as a patient, or a dad of a patient, anybody from my
I think we lost you a little bit, Hans, in the last part of the question.
Yeah, I'm picking up my kids here at school, so sorry for that. The network is not that great. I don't know where I dropped off, but the point that I made was making data fair is so crucial. Make it findable, then make it accessible with the rules that adhere to it. Make it interoperable. When you find something, make it reusable, right? Make it reusable, that's the third thing. Reusable, fair data. Findable, accessible, interoperable, reusable. Because what I ended with is I found a lot of interesting insights. I found trials, I found data, and I want to share that back. So people can call me, people can find the data that I curated. If I curated some data that's now accessible, I want it reusable. And then we can go into the technical aspects of what a patient portal should look like, but I think we first need to get the basics right on data and interoperability.
So Hans, first of all, thanks for all your comments. I mean, it's really terrific. And, after one of these calls, Hans and I had a chance to kind of catch up afterwards. And I think that's been, for me, just terrific. And I'm hoping that we'll continue the conversations not only here on Clubhouse, but also in other mechanisms as well, Hans. So just thank you for that. There's two comments that I would say. One is that one of the comments that Hans raises is that, having access to your own health information is a necessary part of sort of starting this conversation or getting a better handle on what's happening in your health. It's necessary, but it's not sufficient. Because once you've actually had access to that information, it potentially raises new questions or it creates new challenges. And so being able to combine your own health information with other sources of data, whether it's coming from the academic literature, whether it's part of clinical trials, whether it's, putting it in, relating it to other pieces of the health ecosystem, I think that becomes really important. And when we think about health and health data, oftentimes we take a very myopic view. We sort of create this walled garden that's just around health. And I know, for example, there are conversations around social determinants of health as being something that's really important to include. But there is a broad range of social services that, are outside of healthcare, but you probably want to have some kind of connection or communication back in. The principles, Hans, that you articulate, I think are really good. The whole notion of findable, accessible, interoperable, and reusable. But one of the things I pulled out as you were talking about kind of the notion of interoperability, one of the things you mentioned was this notion of not only do I want to be able to get access to all this information and understand it and the complex kind of medical vocabulary. There are existing solutions that can help with some of that with standardized vocabularies, But you raised the second point, which I think is important to sort of tease out, which is interoperability is not just about formats and meaning. It's about understanding. Because if you don't understand the data, it becomes hard for you to make that actionable or to be able to do something with it. And so, even if you had interoperable standardized coding for medical terminology, but you didn't understand that terminology, or that was sort of beyond the scope of knowledge for that particular patient, that interoperability, even around semantics, hasn't provided the kind of access that patients need, which is how do we also make sure that once we've got that standardized and interoperable code for a medical concept, we also have the ability to connect patients to resources that allow them to understand the significance of that and to be able to sort of place that in the larger context, to place it in the larger context of their situation. So with that, I'll stop talking and turn it back over to you, Guillermo.
Thanks, Doug. Thanks, Hans. Hope that answered your question or your comment.
Yes, it does. And again, I don't know if you can hear me because I have a poor connection here in the car. So, but yes, Doug, and you added to it, right? Because ultimately, yes, it's about the semantic knowledge graph that glues data together for people and machine, right? Understandable, but also reusable for machines and AI patterns and stuff like that. And of course, it doesn't end with an EPD, right? It's your wearable socio-demographic data to get a holistic view of a data, to get a holistic view of data of as well a disease as a person and connect things. Thank you.
No, thank you, Hans. I'm going to reset the room. Hi, this is the MedStarter Healthcare Innovators Club. We're talking today with Doug Fridsma, the why of healthcare data beyond patient portals. This is a recorded room, so if you raise your hand and want to have be in the stage, just be aware that by coming on the stage, you are giving consent to being recorded. This is just for purposes of our own record keeping as the club. And if you were interested in the club, just click on the green little Monopoly box on top, and you'll have a little profile page, or you have two links. One with you'll go medstarter.club without the E, medstarter.club. You will find the calendar of all our current rooms that are being scheduled every week. We do a planning session on Mondays. And there's another link for our Discord server in which we save documents that have been shared, links that have been talked about during the conversation, the topics, or ideas that have been fleshed around for example, for a new business adventure, or etc. And having said that, I'm going to give the mic to Matt. Matt, good morning, good evening, good afternoon, good night. How are you?
Hey, morning, Guillermo. Good morning, Doug. Thanks for running these rooms. I kind of enjoy kind of hearing, to be honest, kind of like the history of how all these things kind of came together. I guess the question I have for Doug is kind of around patient portals and access, with the whole open notes thing. Kind of, how do you see that changing the way that patients interact with patient portals, or is that kind of, it won't change much? It's just more data that's going to stream through the same pipe.
So open notes. Let me just by way of sort of full disclosures, I'm kind of a fan of open notes because I think that it is a really it's a good the openness and transparency I think is very beneficial to sort of both the patient-doctor relationship as well as just kind of engaging patients in their care. For those that are in the room that don't know about open notes isn't a technology, but it's really sort of a mission or a brand or it's a campaign in large part to really provide access for patients to all the notes and all the kind of documentation that a patient might or that a doctor or a healthcare provider might have on them. Now, obviously, there are some exclusions to that. There are some protected diagnoses, particularly in mental health, that oftentimes those kinds of notes aren't necessarily always shared. But I think in large part, there is this desire to get that information out and to have that conversation with the patient. I think it's gonna open notes and just that desire to have more transparency about what's written about you and what's in your medical record. I think that's going to change in some sense the relationship that providers and patients have. And I think it's going to be for the good, not to make things worse. You know, there is the desire to sort of track conversations. People say, you know, like if somebody is there's a concern with a patient that they might be drug seeking, for example, there are doctors that might say, well, listen, I wrote in my note that the patient might be drug seeking, and that's not something I want the patient to know. From my perspective, if you think that the patient might have a behavior that is adversely affecting their health and that they might in fact have a problem with addiction or something like that, that becomes a conversation that needs to happen with the patient. And that if you haven't had that conversation, then you're missing out. It could be that there are other issues that are going on in the patient's life. There could be other concerns or problems that are unaddressed, but that are being sort of channeled in that direction. And I think being able to have a conversation about that is actually beneficial to both patient and to the doctor. So I think with the information blocking rules, patients are going to have a lot more access to things. And I think and I think to Virginia's point, and I think she made a really smart comment here, which is you probably want to have those conversations with the patient before the information becomes public, you know, so that people have an understanding, like you should expect this is what's going to happen with a pathology report, and these are the things that could happen. It could be positive or negative, you know, and so you can anticipate some of that ahead of time. Same thing is true in the notes. You know, if you're documenting things that you don't want the patient to see, then it tells me that maybe that you're not having a conversation that needs to happen. And I think while there are edge cases and there are unique circumstances in which it could be detrimental to share that information, I think on the whole we should really treat those as the exception and not the rule, that patients really do have the ability to get that information. And then what we as providers and others need to be able to do is to provide better ways of communicating and kind of engaging them in like, how do we interpret tests and why do we take the tests and what are the results of those tests and things. And I think for the vast majority of patients, that becomes something that is really valuable to their care. And then while there are a few that may be outliers in there, I think we can handle those in a separate way. But I think in general, we really do want that transparency that's out there. So, Matt, I'm not sure that answers your question. It's probably more just kind of a perspective on things. I'm curious if you think there may be other things that might be affected as patients have access to this information and have more ability to take a look at what's in their medical record.
Yeah, no, for sure. And I do want to clarify my question a little bit. So I also, on the open note side, am fully on board, have run a bunch of rooms on them. So open notes in and of itself, 100% agree with. I was kind of thinking more just like the volume of data. Americans, in general, making generalizations here, kind of like some good, more better. And we're kind of feeling that way about all the patient data. But to, I guess, kind of Virginia's point and some of the other patients that I've heard, it's like it can also be an overwhelming amount of information. So I think to add an F to Hans' FAIR principles, filterable probably also needs to be on there. And then kind of what have you seen in terms of patient tools for being able to filter through some of this information? Because I think right now, like, it's either with information blocking rules, people say like, okay, we're going to really pick and choose what goes out there, or other ones are saying, okay, well, if they ask for it, they're going to get all of it, which I think is a little unfair for the patient to have to filter through. So kind of, have you seen who's done it well, and have you seen kind of good tools for filtering? And then not just notes, but like, you know, labs, imaging, like that, because even on the provider side, that's a lot of stuff to filter through. I feel like that's a lot of stuff to filter through on the patient end as well. So if you've seen good filtering mechanisms kind of for the increased stream of data that's coming out.
So Matt, thanks for that clarification. I think there's sort of two things. One, summarization in the filtering is still hard. And I think there is a legitimate concern that there's lots of data that's out there and it can be a little bit overwhelming. What I think I would also do, though, is place this in historical context, in that a lot of this data that's out there, you know, this notion of being sort of overwhelmed by data and by being overwhelmed with patients and their requests and communications and things like that is nothing that's new. This is something that I think we always are behind in our ability to manage the information compared to the amount of information that's out there. And I'll give you, if you'll give me just a few minutes and indulge me, I'm gonna read a quote from this guy, John Kildreth, about kind of information overload. And it's a little bit of a long quote, but just bear with me on this. So the quote is the work of the general practitioner is harder today than it was a generation ago. He is much less independent and has less time to himself. The multiplication of technology makes him more subject to interruptions by his patients, who find it so easy to call him by day or night to ask questions, some necessary, some unnecessary, that they leave him no time in which he can call his own. He is on call at all times, and it is not surprising that while he appreciates the use of this technology, he sometimes regards it as the device of the evil one. He is a slave to the preemptory call of the instrument, and most constantly be ready to answer it, as in many cases no one can answer it for him. That technology and later inventions, each of which in its own way annihilates space and time, greatly affect increased competition by making available for the patient, who for any reason has become impatient, the services of a physician from a distance. Now, that quote is actually from the Boston Medical and Surgical Journal, addressed to the Massachusetts Medical Society in July 26, 1906. And what I did is I dropped out the word telephone and put in technology instead. And so for over 100 years, patients have been feeling that technology, whether it was a telephone, whether it was the automobile, whether it was the electronic health record, has created more dependency, less time, and greater burdens on being able to sort of respond to that technology as well. So the thing is we haven't solved this problem, and it's continuing to be problematic. One would hope that with some of the NLP technology, some of the kind of AI technology, we might be able to get to a point where we can start to answer or summarize some of this information. I know of some sort of stealth startups and others that are working on similar kinds of things, but it is clearly an issue that's going to have to be addressed, because, we're 100 years in and it's still a problem for many physicians to be able to deal with all this information. I'm done talking.
Hey, Doc. Guillermo, can I quickly add something? Hans here.
Sure, go ahead.
Very quickly. So as I started the company to do exactly that, Matt, is how do you filter things, right? And that's part of the findability and accessibility of things. But the point is, what we try to do is we use a semantic knowledge graph to link like layman's terms to like MedRCT, OMOP, SNOMED, FHIR, so that all of these standards overlay and can be filtered and found easily. It's far from perfect, but it's open and free to use. So ping me, send me a DM, and I can show you. And I can do a demo if you want to, but it's free to use for patients and researchers. I'm Hans, done talking.
Thanks, Hans. Hope that answers your question, Matt, or if you have any rebuttal, or are you good? Okay.
I think Matt went to sleep as soon as I started quoting from the 19th century.
I actually went to my safe place. It was a nice quote, though, anyway. To be honest, I appreciate it. Hi, Sarah. Good morning, good afternoon, good evening, good night. How are you?
Good morning. Thanks for the conversation today and inviting me up to the stage. So just to echo some of the comments made here, it's not just access to data that people need, it's access to understanding of that data. That's crucial. And the onus should not, just be on the patient to figure it out and look everything up, right? And so a best practice that I've seen used, especially in telemedicine, is the ability for the patient to see what you're writing real time. And the beauty of that is that your notes and charting are complete at the end of the visit, but it also allows clinicians to also incorporate teach back into the visit so that patients are comfortable with and understand next steps, right? And so I think that there's a lot of opportunity here as it relates to medical technology to help with that understanding of the data, recognizing that, prior to open notes, health literacy was an issue. And now as patients gain access to even more data, they need to understand that within the context of their own lives. So I think there's a huge opportunity for technology to help with some of that translation, if you will. The other issue that I see, well, not just I see, I think we all see, is implicit bias. So we know that implicit bias has been an issue in healthcare, and the words that clinicians use in a patient's record can reflect that bias. And so there needs to be more medical education around this, recognizing that we're putting a spotlight on implicit bias now more than ever, and thoughtfully using humanizing words in a note can help alleviate some of those biases that can also be transferred from one clinician to another in the record. And there was a study that came out recently that explored whether stigmatizing language could influence physician attitudes towards a patient and the decision-making process. For instance, if you treated a patient's pain less aggressively if the patient was labeled a certain way in the chart, and they found that, again, stigmatizing language, it's most likely to perpetuate bias and adversely affect the patient's care. So I think that there needs to be a lot more medical education for the clinician as it relates to writing notes a certain way and even explaining those notes real time to ensure that they're not going to leave the patients with a ton of questions after they gain access. I think we also need to start charting some of the hiccups. So for instance, April 5th was the date that technically people were supposed to get access to their medical records. And I will tell you that we've been flooded with inquiries because patients haven't been able to gain access. And if they were, they were getting access to things like the cover sheet of a fax, not the entire record, if you will. So I think that there's some work to do there, but I think it all starts with medical education for the clinician, but also, the opportunity for innovators to create technologies to help translate that data, because the onus can't also be all on the clinician either. This is Sarah, and I'm done speaking.
Thanks, Sarah. So before Doug, maybe want to interject. So I think you're referring here, correct me if I'm wrong, that when a provider or a healthcare provider writes notes, they should be thinking, because usually when we physicians write notes, we are thinking sometimes better in how would other physician would understand my notes. So there's a common kind of language. And I think what I heard you say is that there should be a little bit more of a not so like peer-to-peer kind of communication, but communication that those notes could be read by a patient and also understand it, and not only somebody who has maybe a background in medicine. That's what I think I understand for your question. And if Doug, you can go next.
So first of all, Sarah, thanks so much for those comments. I mean, I think it's, spot on that, what we record and write about patients, and particularly that persists over time, can actually introduce some biases. So if you call someone, if you use derogatory terms or terms that you wouldn't want the patient to know about, that to me suggests that you may either implicitly or explicitly realize that there are better ways to describe that, and that you maybe haven't had that conversation that needs to happen. So for example, the notion of drug-seeking behavior, if you put that in the note, but you don't actually have the conversation with the with the patient, then in fact, you haven't really told the whole story about that, and that can introduce biases with things. I'm intrigued by your comment about telemedicine visits in which charting becomes part of the visit, because I've gone to physicians in which they actually dictate the note, but they'll do it in front of me as they're sort of talking about through what the assessment plan and things like that is. And I've always been a little bit, it's always been sort of a plus minus in that setting, because I felt like the doctor was speaking to the dictation machine and not to me necessarily. But it sounds to me like in some of these telemedicine visits that you're doing simultaneously charting, and that's visible to the patient, that actually might be a useful thing to be able to do that. What I was going to do is throw that question to Matt, who works as a virtual primary care doctor, to say, to kind of twist that around a bit and say, has patient access to their own data changed the way in which you document, or the way in which you have conversations with patients as a result of that? And if Matt isn't able to answer that, if there's other physicians or providers that want to have kind of address that issue, that would be, I think, interesting to help with the conversation that Sarah has raised. So I'm Doug, and I'm done speaking.
Well,
we'll see. Maybe Matt's just going to be on mute and ignore us. He asked the question, and then he's just in listen-only mode. But I'm just sort of curious, and maybe if Matt gets some time, or if there are other physicians in the room, I'd just be really curious to see if there are others that have found the new rules about electronic health records and patient access to that has changed the way in which they document or in which they deliver care. I'm Doug, and I'm done speaking.
So there's the question right now in general for the whole room, and well, you decide or you think about or you parse what the question. I'm going to go with I think Sarah's with Beth. Hi, Beth. Good morning, good evening, good afternoon, good night. How are you?
Hi, how are you, Guillermo? I just wanted to second a couple of the things that Sarah said. We do need a bigger discussion around the implicit bias. It's pretty well known that folks in the communities of rare disease or even Lyme, chronic disease, even what we've seen as with long haulers, is if there isn't right away a lab test or something that's concrete, what you actually see is some of the notes and information that does often set the clinicians that then follow or the referrals off on a path that does have, for example, a patient that may have an underlying physical problem or a long hauler patient that may have organ damage is instead, referred for counseling for anxiety. We've seen this, huge in the long hauler community, and it is also, I think, understood that there's not a lot of physician training as far as implicit bias. I am a patient advocate. I do participate in a lot of the rooms with the long hauler community and see over and over patients that have a delay in care because of this. So Sarah, thank you for bringing that up. I think it's something that does need to be discussed, and we do need to start to have that better conversation, whether it is seeing those notes at the time so there can be discussion, or that so the patient point of view can be included in the patient record. For example, patient states that they experience X, Y, and Z. It's important. I'm Beth, and I'm done speaking.
So Beth, first of all, thank you for those comments. I think, one of the things that you raise here is, when we talk about biases, there are some biases that are related to sort of racial, ethnic, socioeconomic kinds of biases that get recorded into the chart. But what you raise is actually a slightly different kind of bias, I think, with things. And if people on the room haven't actually taken a look at this, you can do a Google search on a classic paper that was written back in the 70s, but still is relevant today. It's by Tversky and Hanneman, and it's called Judgment Under Uncertainty, Heuristics and Biases. And I think it really provides a way to sort of talk about how people come in and they may have heuristics and biases that help them expedite their decision making, but can oftentimes lead to bad decisions or bad outcomes. Daniel Kahneman won the Nobel Prize in Economics for a lot of the work that he did in around these heuristics and biases. But Beth, the notion that you have here, and it's prevalent in the rare diseases, it's prevalent in the COVID long haulers and things like that, is that, there's an anchoring bias where somebody will come in, they'll have a hypothesis to what the diagnosis might be, and they anchor on that, and it's hard for people to consider other things outside of that. It's probably more common in the rare diseases world, where somebody comes in with a set of symptoms. You anchor on something that is relatively common and more likely, but then when it doesn't play out exactly how you would expect, given sort of what you think the initial diagnoses are, it's hard for people to pivot, to be able to say, well, wait a minute, maybe my initial assumptions were wrong. How can I reset all my biases and look at this in a different way? And so there's a whole host of different biases that can come in with all of that. And so it's important as caregivers for us to be able to be explicit about those sorts of things. Even when we talk about implicit biases that are racial, ethnic, socioeconomic, we know that if you've got a doctor who looks like you will oftentimes get better care. And in those situations, it's a bias of representativeness, I guess is what it is that, this is someone who looks like me. I have a better way of sort of addressing some of those concerns. And we know that, for pregnant women that are having babies, if they've got an African-American caregiver that looks like them, they have better outcomes in a lot of the things that happen. And so as a healthcare system, particularly as we're documenting this stuff, we have to recognize that there are a whole host of inherent biases that everybody is guilty of, and we just want to be constantly vigilant that we don't fall into those traps, because that's where the long haulers struggle, and that's where the rare disease community gets frustrated, because people have these particular biases and it doesn't allow them to sort of get beyond sort of the usual and into those things that really we don't have a lot of experience with. So I'm Doug, and I'm done speaking.
Yeah, thanks, Doug. And I would just add on to that, women often will be referred when really referred for to a counselor or to psychiatrists when, before exploring those physical issues. And so I think it's also male, female, and also patient's age and attributing things that may be typical instead of really doing the listening. I think the listening is key. And if we could see more of that and also more transparency in the data. It does irk me when I go to see a physician and then I read the notes and it's not quite really what we talked about or presented in the same way. So I do think that this is an area that just is sort of ongoing. And now that we do have more access to our data, we have more communication. If we want to have that, Epic My Chart, that it's a great opportunity to get to the appropriate care, whether that is care through, increased mental health services, which is awesome, or whether it's really speeding up getting to a diagnosis and getting the appropriate care, trying to shrink that window of delay of care. And also by doing that, the expenses come down as well. It is prevalent in the rare disease community, but let's remember that rare diseases or, and now even COVID long haul, rare diseases is 30 million of the population. So I think, in this environment today of where we're learning about a new disease, I think we need to take communication to a different level of really listening to the patient. They're going through it. It's something new. So I'm Beth, and I'm done speaking, and thank you for the discussion around the long haulers.
Thanks, Beth. That's great. Guillermo, you want to? We're at the top of the hour. I guess the question is should we reset the room? Are there folks that are waiting to come up and have conversations? If so, we should probably bring them up, and if not, we could consider, putting a pin on this and be able to continue the conversation tomorrow with a more international flavor.
Sounds good. Anybody in the audience has any kind of question, comment, or on the stage or follow-up for the topic in hand, please raise your hand. If not, we will continue this conversation in my room tomorrow at 8:30 a.m. New York time regarding the more, as you said, international flavor regarding beyond patient portals. So if you're in the audience, or if you're still in the stage, you can have another shot at it. I think Virginia wants to say something.
Yeah, I just have one more question about really the use of AI and all this data that is being gathered through portals. And the biases that are built, one of the things we study in tech is the fact that any AI is going to be biased by its programmer. So we need to be having a lot of voices in the beginning as we're programming the AI. And I'm wondering about the data that's being gathered. And there was a discussion, I think, before the room started about how this data was also being available for potentially insurance use and risk coverage and things like that. And I'm just wondering if the AIs that are out there can be turned to help patients in understanding their conditions as well, because patients are going to turn to the internet to find information if they don't find it easily from their physician or from their own knowledge base. And if there is an AI connected to their portal that maybe can direct them to that information, that might provide some of the availability that Hans was talking about earlier, pointing to research studies, journal articles, or credible websites. This is Virginia, and I'm done. Thank you for today's conversation. It's been very entertaining and interesting.
So Virginia, thank you for that comment and question. Let's talk just a little bit. Let me just address sort of the issue around bias. So it's true that you want to have programmers that are going to develop systems and other things like that that don't have implicit biases, particularly when it comes to machine learning and a lot of the sort of predictive analytics and other things like that that everybody would like to have more of in healthcare. Part of the biggest challenge that we have there is that the data that often is used to train these algorithms to come up with the right kind of predictive models, that data itself is biased. So, for example, if what you do is you train these on electronic records that are drawn from the VA hospital, for example, and they were one of the first electronic health record systems, and they have a vast array of different kinds of information, you're going to miss things that might be predictive of women, because women are underrepresented in the VA community. You're also going to miss a lot of young people because there are predominantly older generations within the VA hospitals, although that is changing over the course of the last few years. And so it's really important not only that you have programmers who understand what the implicit biases are, but that when we use data sets to train and to learn kind of what the predictions could be made from the data, that we recognize that every data set that we use is going to have some implicit biases in it, not because people wrote things that might be biased, but in fact that the sample itself is reflective of a population that is different than the population that we're going to be using these technologies on. And I guess the last point that I'll make, and this is the other comment that you made, is that why not have a lot of this stuff be biased towards you? What I mean, by us as patients. Can't we develop ways to search for new information that's biased towards finding information that would be relevant to things that are in your medical record, or that would be relevant to the kind of care that you've received as well? So that people, as they're out there searching, they're not necessarily getting all comers, but they're actually, to Hans's point, this notion of filtering, to be able to sort of drill down a bit, that can be really, really useful as well. So bias is important. We have to recognize it. We can't really eliminate it entirely until we get more representation in the data sets that we use. But I think it's important, if there was any bias that I'd love to see going forward, is a bias towards patients and towards individuals based on their own information, so that the kind of information that comes back is more reflective of their experience and the information that's in their data. So with that, I'm Doug, and I'm done talking.
Thanks, Virginia. I have a question. Talking about after hearing all the people who have talked and spoken on stage regarding how we will be perfect to have perfect in quotes like a central hub, right? But a lot of times information is exchanged externally of this hub. For example, this happens a lot in HIEs or RIOs, in which you start getting duplicate information because another institution sends to another institution that also contributes to the RIO or the hub or the HIE. So how do we deal with that? Because that is something that I have yet seen think people are getting just used to seeing duplicate data or duplicate information, or back at the back end, people just start subjectively deciding which interface to block so you don't have duplicates. So what do you think about of having all this different spaces where patient has information and they create this hub? How do we get rid of this redundancy, and you're going to have a huge encyclopedia just after like maybe 2 months of a medical? Guillermo, don't speak.
So, this is going to become an increasingly important problem, particularly as we move from document-centric ways of exchanging information to data-centric ways of exchanging information. And what I mean by that is that if you get 2 copies of the same progress note, because the hospital had a copy of it and the doctor, the generals had a copy of it, and that both of those pieces of information sent the information to a subspecialist, document exchange like that, you can pretty quickly find out that it was the same note on the same day, and you can kind of get rid of that information. It becomes much harder in a FHIR-based or data-centric way of exchanging information, because now rather than sending that whole document, you might say, here are all the diagnoses that we might have. And if the hospital is off by a day in terms of the diagnosis of a heart attack, and that record is slightly different than the other record, say, from the primary care doctor, a person may have had 1 heart attack, but now suddenly as you merge those things together, you have 2 heart attacks, or you might have 3 heart attacks, or whatever. They get recorded in that information. The same is true, and I think someone mentioned it earlier around kind of medications. Maybe it was Virginia that said, all these lists of medications, some of which I'm on, some of which I'm not. Typically, when they merge these things together, they don't eliminate things. They just add things together. And so now what happens is that you've got duplicates. Somebody might have been on one medication and switched to another. And now because there are 2 different medications from 2 different sources, it appears as if the patient is on both of those slightly different medications, but for the same function. And this will be increasingly a problem. If you take a look at the meaningful use rules that came out, or I shouldn't say the most recent regulations, not the information blocking ones, but the ones around sort of information exchange based on APIs, they added a new field called Provenance, which was really intended to be able to trace information back to its source and to be able to determine its validity. That was sort of the solution that was proposed, or that's part of the current regulatory framework. But there's a lot of other ways to do that. You could have a canonical source of information with only a link that's shared, and there was some early work. There was some early work in something called PCAST in the Obama administration to try to create a way that discrete data could be shared, but it would always be sort of linked back to its original source. So this is going to be a problem going forward. There are some things like blockchain that could potentially be used for this, but I think as more and more information gets exchanged without a certain amount of discipline, you're going to start to have some errors that may creep in with duplication. The last thing I'll say, and I don't know who brought it up, but the whole notion of the patient is the only person who really fully understands all of the things that may have happened to them, and that if they have a copy of the record, they're the ones that are going to be able to most easily deduplicate their record to say, this is incorrect, I'm not on this medication, this visit is a duplicate of something else that happened. All of those things, the patient is the one who has the most vested interest in making sure that record is correct. And they also are probably the most efficient at just checking to make sure that all of the information is accurate without duplication. With that, I'm Doug Fridsma, I'm done speaking.
Thanks, Doug.